Now I'll discuss vaginal birth after cesarean section, VBAC. So through this outline, introduction, the evolution of VBAC, contraindications to VBAC, selection of patients for VBAC, then prediction of successful VBAC outcome, then management of VBAC, then we'll talk about controversies surrounding VBAC, and I'll conclude. So, by way of introduction, management of a woman who has had a previous cesarean section is one of the most controversial issues in obstetrics. And of course, there's rising cesarean section rates. WHO currently recommends 10 to 15% cesarean section rate. The increased rates, as I mentioned during the discussion on cesarean section, include safety of surgery now, then small family size, and older women, then high level of litigation, then electronic fetal monitoring and misdiagnosis, epidural anesthesia, use of epidural anesthesia, reluctance of vaginal breech delivery. Then some of us are not patient enough to monitor labor. Then it may be more convenient to do cesarean section. So now, there was this dictum in 1916 that once a cesarean, always a cesarean. And then there was no antibiotics. I mentioned that antibiotics was actually discovered in 1928 by Alexander Fleming. There was no blood banking. Fetal monitoring was poor. Then, of course, classical scar risk were the basis. So in 1920, Kerr introduced the technique of low transverse uterine incision. And lower segments since 1940 became popular and classical declined. Blood transfusion and potent antibiotics are now available. So in 1961, River et al. Actually challenged the dictum, but of course his reports were generally ignored. So in 2010, Harcog stated that most women with one previous cesarean section with a low transverse incision are candidates for and should be cancelled about VBAC and offered trial of labor after cesarean, which they call TOLAC. So now, how can we reduce cesarean section? Cesarean section can be reduced by understanding the physiology of labor, active management of labor, and use of oxytocin augmentation, intrauterine pressure monitoring, fetal monitoring and fetal scalp sampling, then obstetric forceps, and of course, use of ventus, that's the vacuum. Then, use of prostaglandin for cervical ripening in case of prelabor rupture of membrane. Then, beta mimetic in uterine hyperstimulation. Then, of course, the patient should be educated on childbirth. So, I'll take you through evolution of VBAC. In 1981, NIH task force suggested that VBAC should be encouraged. And of course, I talked about Harcog's statement. Then, of course, now numerous meta-analyses and other studies testify to the safety of VBAC. Overall fetal outcome is comparable to uncomplicated pregnancy and maternal morbidity is low. And overall reduction in health costs. You can see the reference there. Some workers made it mandatory that in the absence of contraindication, every woman, eligible woman, should actually have VBAC. In 1988, VBAC rate was only 3% in the United States, about 3% in Canada in 1991. In the mid-90s, Danforth said that the question now is not whether the dictum of automatic repeat cesarean section is still valid, but rather why we continue to adhere to it for more than 60 years as though it has been carved in stone. So in 1990s, the rate increased to 28% in US, that's 1995 to be specific, then 33% in 1994, that's in Canada. Then Nigeria's cesarean section rate currently is 22 to 25% hospital-based studies. So now, according to World Health Organization in 2015, cesarean section among women with previous CS ranged between 78.1 and 79.4% in high-income countries. Then in middle-income countries, you have the highest incidence, which is between 85.2 and 87.5%. In low-income countries, it's between 63.2 and 72.1%. So now, what are the benefits of VBAC? There's lower maternal death. In fact, it's said to be about 2 to 3 times less. There's less blood loss when you compare it to elective repeat cesarean section. There's decreased risk of infection. There's prevention of injury to structures like the bowel, urinary tract. Then there's decreased risk of thromboembolism. There's less need for anesthesia and analgesia. The feeling of guilt as felt by some patients, especially in this environment, is less. Then there's greater sense of accomplishment on the part of the woman, which many of us don't pay close attention to, but it is very important. Then breastfeeding is generally easier after a vaginal birth. Then it's cost effective. It's far cheaper to have a vaginal birth compared to cesarean section, especially in low-income countries where the facilities are not readily available. Then faster recovery and shorter hospital stay compared to elective repeat cesarean section. Then, of course, what are those benefits to the baby? There's less risk of prematurity. Labor prepares the baby for life outside the womb. So there's less breathing problems, fewer perinatal deaths, prevention of surgical injuries to the baby in form of lacerations, fracture of bones. Then, of course, there's more opportunity for the mother and the baby to interact for family bonding, which is very important. So now, what are the contraindications to vaginal birth after cesarean section? Of course, if a woman has had classical cesarean section before, I mentioned earlier that the risk may be as great as 4 to 7%. Then some uterine surgeries like hysterectomy, mammectomy, with endometrium breached, corneal resection, and metroplasty because of high risk of uterine rupture. Then previous uterine rupture or dehiscence. In fact, there's this ductum that you don't send a soldier to war twice. You may have to tie the tubes, especially if the rupture is so bad. Then some maternal and fetal medical conditions such as open neural tube defect and complete placenta previa. Then unknown uterine scar if there's high likelihood of classical scar. So now, what are those conditions with increased risk? 2 or more previous cesarean sections, previous failure to progress in labor and or cephalopelvic disproportion, short interpregnancy interval of about 9 months, pre-pregnancy weight in excess of 136 kilograms. Then, of course, when there's need for induction of labor. So now, conditions with no documented increased risk, post-cesarean section infection, over-distended uterus seen in twins, macrosomia, hydramnios. Many of us may not want to consider VBAC in them because of the risk. So now, selection criteria as put forward by Harcourt in 1998. 1 or 2 prior low transverse cesarean section, clinically adequate pelvis. That means there's need for clinical pelvimetry. Then no other uterine scar or previous rupture. Then there must be a physician that is able to do emergency cesarean section on ground even before we start at all. Then availability of anesthesia and, of course, personnel for emergency cesarean section in addition to the physician. So now, how can you predict a successful VBAC? It's been said that overall success rate is as high as 60 to 80%. In fact, some centers record higher success rate. So now, the maternal characteristics. It's been said that when the woman is tall, the likelihood that it's going to succeed is higher than the weight and the BMI of the woman. If there's lower success rate in women with weight greater than 136 kilograms. Interestingly, we don't see women greater than this weight often in our practice. So then the age greater than 40 years, the risk is said to be about threefold compared to younger women. Then if the birth weight is more than 4,000 grams, the risk is said to be threefold. Then let's talk about current labor being a predictor. If there's some induction of labor, the risk of failure is about 2 to 3-fold. Then cervical dilatation in labor greater or equal to 4 centimeters favors vaginal delivery. Then the attitude of the physician is important. So now, Weinstein in 1996 put forward a scoring system which can be employed to predict the success of VBAC. When Bishop's score is greater or equal to 4 centimeters, it's equal to 4. So you give the woman a score of 4. Then, if the individual has had vaginal delivery in the past, you give a score of 2. Then past indication, we have 4 groups. Group A, malpresentation, PIH, and twin, will have a score of 6. Group B, APH, PROM, prematurity, that's the indication for the previous years, 5. Group C, distress, that's fetal distress, CPD, called accident, will have a score of 4. Group D, macrosomia, and high GR, we have a score of 3. So now, if the total score is 4, the success rate is predicted to be about 58%. If the total score is 6, success rate is predicted to be about 67%. If it's 8, it's about 78%. 10, 85%. 12, 88%. In essence, the higher the score, the better the prognosis. So now, outcome parameters. How do we measure the outcome of VBAC? There's maternal, there's fetal. So maternal outcome, is there mortality? Is there uterine rupture? Is there hysterectomy? Postpartum hemorrhage, bladder injury, infection, and fever. That's in the mother. In the baby now, is there mortality? Then Apgar scores at 5 minutes. Then, of course, length of hospital stay. So you can see the outcome of trial of labor after cesarean TOLAC or VBAC, then elective repeat cesarean section, increased is represented by plus, decreased is represented by minus. Then, of course, in bracket, that's 95% confidence interval. So you can see. The risk. So let's talk about uterine scar rupture. When it's low transverse incision, the risk, as I mentioned, is often less than 1%. Then when it's low midline, usually in most books, it's between 1 and 7%. But if it's classical, it can be as high as 12%. But some workers will say 4 to 7%. So now, you can actually detect scar dehiscence even before pregnancy. In 1984, it was said that if you do HSG before pregnancy, you may see dilatation, narrowing, and diverticular at the isthmus. Then, when ultrasound is done in pregnancy, you may be able to see a window in the lower uterine segment. That's created in 1991. Then, during labor clinically, intracervical palpation at 3 to 4 centimeters, and of course, electronic monitoring, of course, can help us predict possibility of scar dehiscence. It's been said that the earliest abnormality that is seen is actually fetal heart rate abnormality. Then, of course, you can detect it at cesarean section. Then, in 1980, so by Professor Okpere, it was stated that postpartum scar palpation may actually help you detect whether there is dehiscence or not. So now, presentation and management of scar dehiscence. Of course, there's acute pain and tenderness, vaginal bleeding with hypovolemia, cessation of contraction. You may lose the station. In fact, that may be the first sign you see that the station is not getting better, it's even worse. So now, then acute fetal distress, bradycardia, late or variable deceleration. Of course, how do you manage? You resuscitate, then laparotomy and delivery becomes an acute emergency, so you have to intervene immediately. Then, of course, you may have to do BTL, and if there's intractable bleeding, you may have to do hysterectomy. So now, management of VBAC. Appropriate center with facilities and personnel, as I mentioned earlier. Then the management should even start at preconception level. Then you have to review patients in totality, and you have to select your patients appropriately. Then antenatal counseling with options. The patient must know the benefits and the risk. Then you must encourage VBAC in the patient, because the way you counsel the patient may affect what the decision of the patient is going to be eventually. But of course, you have to respect your patient's decision. Then you continue counseling, and of course, there's need for you to assess and reassess patient's choice. Then informed consent, clinical perimetry, radiological perimetry is optional. Then there's low risk. The pregnancy has to be low risk except for the scar that the individual has. Then spontaneous labor is often advocated, and the patient should present as early as possible in the hospital. You must inform the other members of the team, the anesthetist, the pediatrician, the theater staff, then the blood bank. Then you have to secure an intravenous access. There must be an intravenous access in place. Then use a pathograph. Then there must be close monitoring of the fetus. In centers where electronic fetal monitoring is not available, it's not compulsory, but there must be close monitoring. But of course, it's preferable to use an electronic monitoring. So epidural analgesia is optional, it's not compulsory. Then there must be need. There's actually need for childbirth support by the spouse of the woman and, of course, the family members. Then labor abnormality should be reviewed carefully. There may be need for use of episiotomy. And of course, after delivery, you don't neglect the woman. There's need for postpartum observation. And as much as possible, avoid routine exploration, because you may even be the cause of the dehiscence yourself if you are not careful. So now, what are those factors that influence patient's choice? Based on studies, it's been discovered that ethnicity, hospital setting will affect the patient's choice. Others will include recovery time, desire for natural birth, presence of support by family and the spouse, then fear of major surgery, convenience on the part of the woman now, and even the physician, then fear of labor and pain, then perceived low success, when there's no drive that it's going to be successful. Then if there's need for BTL, then that may drive the patient and physician towards abdominal delivery. Then maternal age, education, religion, income, prior birth experience, perception of danger to mother or fetus, then, of course, the advice of the physician, then opinion of spouse and friends. In fact, their opinions may even hold more water compared to that of the physician. So now, what are the controversies? What we call recurrent indications. Different workers have different conditions that they call recurrent indications. Then when you have twin pregnancy, breech, induction of labor, oxytocin, prostaglandins, then whether or not epidural anesthesia should be made compulsory, then electronic monitoring too, whether it should be made compulsory or not. Then when you have more than one scar, I know many of us will not go for VBAC if the scar is more than one because of the risk associated. Then when you don't know the type of cesarean section scar the individual has, it may be classical, which is associated with high risk of uterine rupture. Then, of course, routine lower genital exploration. Some workers still advocate this, but I think most of us now kick against this. So now, another controversy is who should supervise VBAC? Who should supervise VBAC? That's another controversy. Some will tell you that it has to be a senior registrar. Some will say it has to be a consultant. So that's another area of controversy. Then, of course, the changing trend. Let me talk about the changing trend. There is a question that we are often asked now. Should VBAC be encouraged in the face of increasing safety of surgery and now increasing concern about fear of uterine rupture and litigation? So we all keep answering this question in our minds. So, by way of conclusion, cesarean section is safe, but it is not without complications. Reducing primary CS rate will in turn reduce overall prevalence of cesarean delivery. And patients with primary CS should be carefully assessed for VBAC. VBAC is safe in carefully selected patients. We all must know this. Then the woman and her healthcare provider must decide together whether an appropriate situation exists for considering a trial of labor after cesarean section or an elective repeat cesarean section. Thank you for your attention.